Hello, welcome to my introduction to rheumatology talks. I've been a rheumatologist in practice for over 30 years, and during that time I've had the opportunity to give lectures to sophomore medical students in their Introduction to Medicine course on rheumatology. That's the basis for the lectures that I'm going to give. I've tried to avoid using jargon as much as possible when I made these, but occasionally I may use a word that I don't explain well. If I do, just feel free to look it up. The word could be typed into Google and you can generally find the meaning of it. The lectures will be posted in the order in which I made them, although many times they'll stand by themselves, so one doesn't necessarily need to watch all of them, and certainly you can pick and choose which talks might be of interest to you. I hope this is helpful to you and informative, and I hope that you learn something. Thank you for listening to my talks.
Hello, my friends. Today we'll be talking about osteoarthritis. Osteoarthritis is the most common type of arthritis, and the type of arthritis that most people think about when they hear the word arthritis. Now, osteoarthritis basically is a condition where the cartilage wears away, or what we have cartilage loss. Now, this is somewhat of a simplistic definition, as there's also changes in the underlying subchondral bone and the supporting ligaments and the capsule of the joint and even the synovium. The periarticular muscles are also involved. It is degenerative, that is, there is cartilage failure. It's not autoimmune like rheumatoid arthritis or lupus, and it's just perhaps a very small inflammatory response. Why do people get osteoarthritis? Age is perhaps the strongest factor. From age 25 to 35, there's only about a 0.1% incidence of osteoarthritis. But when we get above age 55, there's at least an 80% incidence. Now, in a way, this may be genetic. It's part of our programming. We've all had experiences with other species. In particular, I think about dogs. Dogs get osteoarthritis at a very age, 10 years old, whereas humans don't get it till well into their 50s and 60s. Women are also at increased risk for osteoarthritis, and I will say that I'm not sure why that occurs. Now, the next series of things that I'm going to talk about may be due to abnormal stresses on the joint. Obesity is the single greatest modifiable risk factor associated with the development of osteoarthritis. And that even includes non-weight-bearing joints such as the hands. I put lack of osteoporosis. There is data to suggest that if the underlying bone underneath the cartilage is not osteoporotic, that there may be an increased risk of osteoarthritis. However, there's been some studies that have shown just the opposite also. Certain occupations are at increased risk for osteoarthritis. And again, I think this is due to stresses on joints that may be not normal in other jobs or other types of occupations. In particular, the knee has been linked with cotton workers and dock workers and shipyard workers, and other osteoarthritis has been linked to other occupations. Certainly, we've all heard about sports injuries associated with osteoarthritis. Certain sports such as the knee in football or the forefoot in ballet, which obviously is not considered or thought about as a sport. However, the amount of conditioning and strength that the ballerinas have certainly puts them on the order of an athlete, and because of the way they use the joints, they are at increase for osteoarthritis in the forefoot. Now, interestingly, at least to date, I've not seen any associations of running with osteoarthritis of the knee. Previous injuries can change the ligaments and the muscles that support the joint. There can sometimes be meniscal injuries, and this can predispose to changes in the stresses on the joints and osteoarthritis. Weakness can be associated with osteoarthritis of the knee, and in particular, people that have weakness of the quadriceps muscle are more often predisposed to osteoarthritis of the knee. And again, this is an abnormal stress across the joint. Increased hand strength has been associated with development of osteoarthritis of the proximal joints in men. So that's sort of the opposite. In the knee, if we see weakness, perhaps there's more osteoarthritis. But in the hand, if the hand is used more, there's more osteoarthritis. Now, interestingly, neural anatomically normal joints are increased risk of developing osteoarthritis in the absence of adequate exercise and are not at increased risk when exposed to low impact exercise. However, high impact exercise can increase the risk, whereas neuroanatomically abnormal joints are at increased risk with repetitive or low impact exercise. And that's neuroanatomically abnormal people that for some reason do not have good sensation of the joint, so can't tell what's going on. People that have proprioceptive defects, in other words, inability to determine where the joint is, have an increased risk of osteoarthritis. An example of this is what we call a Charcot joint in diabetes, where they'll get very remarkable osteoarthritis of the foot. Genetics plays a role in osteoarthritis. In twin studies, they find that there's at least a twofold increased concordance of identical twins versus non-identical twins. And it's estimated that genetics is about 39 to 65% of the cause of osteoarthritis. There are genetic defects of collagen that have been associated with families or cohorts of people with osteoarthritis. It also looks like people that carry a hemochromatosis gene are at increase of osteoarthritis. Hemochromatosis is not really an arthritis condition, it's a condition of iron deposition in the liver, but this has been shown to also be associated with osteoarthritis. And then there's families with a condition we call chondrocalcinosis and premature osteoarthritis. Now, acromegaly may again be an abnormal stress across the joint causing osteoarthritis. Acromegaly occurs when the pituitary gland produces too much growth hormone. Children that have acromegaly actually become what we call giants. They become very tall, very large. And adults that get acromegaly can have increases in the size of their forehead, their nose, their hands, but this can also be associated with an increased risk of osteoarthritis. And then chondrocalcinosis is associated with osteoarthritis. Now, this is a condition of deposition of calcium along the cartilage. It's not clear if this is a cause of osteoarthritis or if this is a secondary response to osteoarthritis. The pathologic changes in osteoarthritis include degradation of the articular cartilage, thickening of the subchondral bone, and formation of osteophytes, variable degrees of inflammation of the synovium, and degeneration in ligaments. In the knee, there's a degeneration of the menisci and hypertrophy of the joint capsule. Other structures such as the periarticular muscles, nerves, bursa, and local fat pads also contribute. So what's going on in the joint? If you look at normal cartilage is very smooth, okay? And there's sort of an even spacing of the chondrocytes, the cells of the cartilage in the cartilage. This is the subchondral bone. In osteoarthritis, the normal cartilage breaks down, and we see this fissuring and cracks in the cartilage. The chondrocytes try to respond to that, and what we see here is they're actually multiplying, whereas there was only one chondrocyte in each of the lacunae in the normal cartilage. We see multiple chondrocytes in the lacunae. There's a change in the underlying cartilage, and the chemical makeup of the cartilage changes. So the chondrocytes, when activated and start proliferating, also increase production of matrix proteins and matrix degrading enzymes. And this is an injury response which ultimately leads to matrix remodeling and then inappropriate hypertrophy and cartilage calcification. The matrix degrading enzymes can break down the cartilage, and once the collagen network is degraded, it appears that it cannot be reversed, and we're going to go over that in a second. Once the collagen network is broken down or degraded, it cannot be reversed. In order to explain that, let's review some of the anatomy we learned in our first lesson, the Introduction to Rheumatology. If you recall, a cartilage, which is the functional structure of the joint, sits on the end of the bone, as we show here. Basically, what cartilage is, one has these collagen fibers which are anchored in the bone. You have this cross mesh of collagen fibers, and captured in that are the chondrocytes, the cells of the cartilage, and these huge molecules called proteoglycans or glycosaminoglycans that are very hydrophilic. Well, one can imagine that if this cartilage, if these collagen fibers break down, that structures that are captured in there, including the proteoglycans, can escape, and that changes the structure and function of the cartilage. We talked about changes in the cartilage. There's also changes in the underlying bone. Wolff's hypothesis states that the distribution and material properties of bone are determined by the magnitude and the direction of the load applied. And what we find in the bone is that there is bone remodeling, and we get these bone spurs or osteophytes as a result of this. Now, why this occurs, we're not sure, but obviously there probably is some abnormal stresses across the joint, or there are abnormal stresses across the joint leading to this. This may also be a reaction to the effect on the tendons and ligaments as they attach to the bone, what we call the entheses. But what we see in osteoarthritis then is the development of these bone spurs or osteophytes. The synovium can also be involved in osteoarthritis, although not to the degree that it is in rheumatoid arthritis. Here you do see some mild inflammation of the synovium. Again, this is not a big thing in osteoarthritis, and when we talk about the joint aspiration, the fluid we obtain from the joint, typically there's not much or any inflammation in that. Now, pathologically, what we see, and we've seen sort of representation of this before, these are just more directed pictures. We see fissuring, breakdown of the surface and fissuring of the joint. There's these clefts that are in the joints. There's clusters of the chondrocytes. Again, they're proliferating. They're multiplying, trying to repair the damage that has occurred. The water content of the joint changes. So in the comparison picture, we saw how the cartilage stained much paler when there was osteoarthritis than when there was normal cartilage. Again, we can see the staining, see how in this stain, and this is a safranin O stain, which sort of has an affinity for proteoglycans. We can see that there's less when we move into the osteoarthritis cartilage. The physicians see clinically in the office. Typically on presentation there's joint pain, although I would state that I've found osteoarthritis in patients doing my typical rheumatology exam, looking and squeezing all joints, where they do not have pain in every joint that has osteoarthritis. Usually the onset of pain is insidious, and this can take generally years before they really get to the point where they present to a physician. Again, this is different than rheumatoid, where it can be usually within days, weeks, or months. The factors affecting the pain is typically better with rest. However, there is a little bit of stiffness in the morning, and usually this may only last 15 to 30 minutes. We call this gelling. This is different than rheumatoid arthritis, where the stiffness can last hours. Usually the number of joints is not many that are bothering. It's generally few, and again, we'll contrast that to rheumatoid arthritis, where there's many joints involved. Functional impairment is very important to note during the history and examination. It's important to find out if they have trouble going up and down the stairs. That can be affected by knee osteoarthritis. The hip can actually cause difficulty putting on and taking off the socks. This is external rotation of the hip, and this is internal rotation of the hip. And you can see I actually do have some decreased internal rotation of the hip and may have some osteoarthritis. But in putting on a sock, one has to sit and externally rotate the hip. With respect to the hands, they can have trouble with the first carpal metacarpal joint, which is right there. And thus they can have trouble with pinching and gripping. One wants to know how this is affecting their work. When we get to treatment, we're going to talk about how our main goal with osteoarthritis is to try to maintain function. So certainly an important part of our function is our work, and we want to know how that's affected. And also activities of daily living, not just work, but things they do at home, how they do with taking care of chores around the house. If there's any hobbies or avocations, we want to know about how that's affected also. The risk factors have already been stated for osteoarthritis. This was listed under etiology. Generally, it's older individuals, most often greater than 40, but not exclusively. On physical exam, one can find crepitus or crunching of the joint. Now, again, none of these is 100%, but that's very common to find crepitus. We look for bony enlargement of the joints. You can see that here. And I would submit if you were to feel that joint, it would be very hard. Again, this is different than rheumatoid arthritis where it's soft and smushy. And this is just, again, an anatomic specimen where you can see the osteophyte. Here is x-rays showing those. And again, you see these little spurs or osteophytes on the distal interphalangeal joints and the proximal interphalangeal joints. This is an example of the osteophyte of the knee, and what you see in this knee x-ray is that there's a lot of narrowing of the medial joint space. See how that's narrow compared to the lateral joint space. What's in that space is cartilage, and when it's narrow, that means the cartilage has gone away. You can see the bone spur there. These are deformities that can occur. This is what we call genu varus, and what that means is that the foreleg is sort of bowing in, sort of like bow legs. This is what we call genu valgus. The foreleg is bowing out, causing sort of a knock-knee appearance. And this is an x-ray of somebody that has genu valgus on the left knee, and you can see the narrowing here. I'm looking at these anatomically. That means I'm looking like I'm looking at a patient where this is the left side, that is the right side. And they have medial joint space narrowing on the right side. So genu valgus, genu varus, when this pattern occurs, we call it windswept knees. There can be instability of the joint, and we feel that by examination. They can have decreased range of motion of the joint. We did talk about how the hip's affected with internal rotation and external rotation. The knees we can measure with a device called a goniometer, which actually measures the angle of the joint, and we can show that there's loss of motion. We can cause pain in the joint by stressing it. Now, the distribution of joint involvement in osteoarthritis helps us make the diagnosis. It is somewhat different than rheumatoid arthritis. It can involve the cervical spine, the lumbar spine, and we never see the lumbar spine involved in rheumatoid arthritis. Of the hand, we see distal interphalangeal joint or DIP and proximal interphalangeal joint or PIP involvement, whereas in rheumatoid arthritis we see PIP involvement and metacarpal phalangeal joint or MCP involvement. Typically, the base of the thumb can be involved. We call that the first carpal metacarpal joint, whereas in the rheumatoid, we don't see that joint involved so much as the wrist, and we tend not to see osteoarthritis in the wrist unless there is what we call chondrocalcinosis. The knees can be involved in both, the hips can be involved in both, In the foot, we don't typically see it in the ankle as much, but we can see it in the forefoot and we can see it in the first metatarsal phalangeal joint. I just want to bring to your attention a couple of special subsets of osteoarthritis. This is nodal generalized osteoarthritis, and basically there's a lot of involvement of the distal interphalangeal joints and proximal interphalangeal joints with what we call Heberden nodes and Bouchard nodes. This tends to have a female predominance. It tends to peak around menopause, and there does seem to be a strong familial distribution. Typically, the function remains good in spite of the fact that the hands look so funny. There is a predisposition to osteoarthritis of the knee, hip, and spine associated with this. Another subset is inflammatory osteoarthritis, and this can sometimes have onset with inflammation, and that can cause a challenge as this can look somewhat like psoriatic arthritis, although typically as one follows it forward, the inflammation subsides and one's left with an osteophyte, a hard osteophyte, and not a lot of pain. Now, the test that we do to evaluate osteoarthritis, probably the most important test, is the X-ray. And we just talked about what this X-ray shows with the medial and lateral joint space findings and the extra bone growth of the osteophytes. Again, we've seen this X-ray already, and again, we see the osteophytes here and the joint space narrowing. Hand X-rays, we've seen these again with the loss of the joint space and the osteophytes here. These, by the way, are called gull wing deformities, if you ever see that on X-ray. There's not a lot of erosion, but you may see some around the gull wing. There can be involvement of the first carpal metacarpal joint, and that's what we're seeing down here. There's a lot of joint space loss. The other thing that you see on this X-ray is there's a lot of what we call periarticular sclerosis. The bone on X-ray is wider around the joint, which means it's actually denser. This is an X-ray of the hip. This is a more normal hip. I don't know as I would just say it's totally normal, but you see the normal joint space here where the cartilage is. On this side, the cartilage is totally obliterated, and you see what we call subchondral cysts. These are sort of this areas of decrease, sort of like holes in the bone. This is a spine with osteoarthritis. You're seeing a few things here. Number one, on this side there is some narrowing of the disc space. There's a lot of osteophyte formation. That's what these things are sticking out here. And the other thing is you do see a lot of sclerosis of the bone. Again, increased density. The facet joints are sort of hidden in here, but you can sort of get the sense that there's increased density around the facet joint. Again, consistent with osteoarthritis. Synovial fluid aspiration from a joint is helpful. The fluid is non-inflammatory, and we'll talk about that later when we talk about synovial fluid evaluation, but this is a non-inflammatory fluid, which means it's fairly clear. If you can look, you can see through it. There's not a lot of cells in there. I don't typically get a rheumatoid factor. However, if one looks at the criteria for osteoarthritis in the knee, that includes a negative rheumatoid factor as one of the classification criteria. Acute phase reactants I do often get. These are things like the erythrocyte sedimentation rate and the C-reactive protein. These are generally normal in osteoarthritis. The diagnosis of osteoarthritis is generally pretty easy. Basically, what I look for in order to make the diagnosis is radiographic or X-ray changes, and those are generally almost diagnostic. On exam, I look to feel if there's any bony enlargement of the joint as opposed to the soft enlargement we feel like with rheumatoid arthritis. And I look to make sure that there's not an inflammatory process or an inflammatory arthritis going on. So those are the things I look at clinically. Now, we talked about classification criteria when we talked about rheumatoid arthritis and lupus. And again, classification criteria are primarily to help us recognize something as being that diagnosis, osteoarthritis, for the purposes of clinical studies. So we can do studies on the patients, make sure everybody in the study has the same diagnoses. So these are just some classification criteria. This is based on if you just do a physical exam and do blood work. This is based on if you do x-rays, and this is based on if you just do a physical exam. And I'll go to this diagnosis if you do x-rays is pretty easy. If they have osteophytes and knee pain, and at least one of these three things, you can make the diagnosis, okay, or at least the classification for studies. If you have lab tests, again, you want to have knee pain. You don't want to find clues of an inflammatory arthritis. So that's why they put SED rate less than 40, negative rheumatoid factor, and the synovial fluid consistent with osteoarthritis. And if you make a clinical diagnosis and you don't have x-rays and you don't have lab and you want to make the classification for studies, then they want you to have at least three of these things: joint pain plus at least three of these things, including age, stiffness less than 30 minutes, crepitus or grating with range of motion, tenderness of the bone, bony enlargement by palpitation, and again, no palpable warmth. In other words, no clues that there's an inflammatory process going on. For the hand, again, same issue. You want hand pain or stiffness, and at least three of the four following. Again, you want to have bone enlargement, and the 10 selected joints are the DIPs, PIPs. You want to feel it is a hard enlargement. You do not want to have swollen MCPs because that would lead you to suspect other things like rheumatoid arthritis, and you want to see deformity. Again, these are classification criterion in my practice, sort of like seeing zebras. When you see one, you know it's there. You don't have to guess what it is. This is for the hip, and again, pain in the hip. Again, no evidence of inflammation and evidence of x-ray changes suggestive of osteoarthritis of the hip. So these are the common features of the criteria. There has to be pain in the joint, there has to be increasing age, and there has to be the presence of osteophytes. So what looks like osteoarthritis? What's in the differential diagnosis? Calcium pyrophosphate deposition disease, or CPPD, can be associated with atypical osteoarthritis and in joints that we don't usually see osteoarthritis in, and that's things such as the shoulders, the wrists, the metacarpal phalangeal joints. It also shares many of the joints that osteoarthritis does. It can be associated with a type of inflammatory arthritis called pseudogout, and we'll discuss that when we get to our discussion about gout. Some people would consider it a subset of osteoarthritis, and it may be part of the abnormal healing response that we see in osteoarthritis. Rheumatoid arthritis is listed here, although typically there's much wider joint involvement in rheumatoid than in osteoarthritis. The distribution of the joints is different than osteoarthritis, and there's a lot of inflammation. So large joint involvement could be similar. Infectious monoarticular disease. Infectious arthritis generally presents with just one joint or no more than one or two joints involved. Osteoarthritis usually presents with just one or two joints. So it's very important to determine if there's inflammation and infection going on, and thus very important to aspirate a joint if there's a question. Psoriatic arthritis has a subset that includes just distal interphalangeal joint involvement, and so has to be considered when we're looking at osteoarthritis of the hand. Let's talk about the treatment of osteoarthritis. I think before we march into this, it is important to state that there is no disease-modifying anti-osteoarthritis drug. That is to state there is no medicine that changes the outcome of the disease. And so our goals primarily are to decrease pain as much as possible and maintain function as much as possible. Given this, we are not willing to subject our patients to highly risky therapy because there is not a lot to be gained for that. Now, probably the non-pharmacologic treatments are really the most important things to do in the management of osteoarthritis. With respect to the hands, we send people to the occupational therapist to learn things like how are they going to use their hands when they function less well, what we call activities of daily living, tricks around problems that they're having, maybe some tools to use, and also some hand exercises. With respect to the hip and knee, exercise is key, both cardiovascular exercise and strength training. Weight loss in somebody that's overweight is also very important. Now, patients often ask me about what they call natural therapies, and I will say I don't think there's anything more natural than exercise and weight loss. To me, something ingested, be it manufactured with a known target, known benefits, and known side effects, such as a pharmaceutical drug, or a plant or animal-based product where we have an unknown melange of unpurified chemicals with unclear targets, unclear benefits, and unclear risk, and I'm referring to sort of the health food or the nutraceuticals out there. I don't see a difference. To me, both of those are not natural. The most natural treatment is exercise, cardiovascular, strength training, and weight loss. Patients instructed in the use of heat to help with the pain in the joints. Walking aids such as canes and walkers can be of benefit. Knee bracing likewise can maintain function. There are some self-management programs that go over ways to live with this. And again, a lot of that's supplied by the physical therapist. And then supervised exercise can be of benefit. Now, we do use pharmacologic treatment. Again, this is more often to try to help the pain. A lot of the discussion that's going to follow is from the 2019 American College of Rheumatology guidelines for the management of osteoarthritis. Topical capsaicin or topical nonsteroidal anti-inflammatory drugs are a safe option. Oral nonsteroidal anti-inflammatory drugs such as ibuprofen or naproxen or COX-2 selective nonsteroidal anti-inflammatory drugs such as celecoxib can be a benefit and feel better, but they do come with a high risk. They do come with the risk of kidney toxicity, high blood pressure in particular, and non-COX-2 selective with respect to GI bleeding. Tramadol is also listed. Tramadol is a weak opioid agonist, but it also has some properties of weak serotonin and norepinephrine reuptake inhibitor, which is sort of like an antidepressant. So it has properties of both, and it can be helpful, although in the US right now it's currently managed as a narcotic, and thus there's a lot of challenges and barriers to its use. In the past, I've strongly favored acetaminophen and have used it a lot, although the current guidelines from the American College of Rheumatology do not as much. It's sort of conditionally recommended. It's not felt to be all that effective, and at least in some studies has shown to increase the liver enzymes. Intra-articular injections of cortisone or corticosteroids can help and are favored. Duloxetine or Cymbalta has been suggested to have benefit. And then lastly, opioid analgesics, narcotics are not recommended in the treatment of hand osteoarthritis. Guidelines for osteoarthritis of the hip and knee are similar. Again, acetaminophen I've favored in the past, but it's now only conditionally recommended. The nonsteroidal anti-inflammatory drugs can be of benefit, but again, these are really a problematic medicine in a population that is aging, because they can adversely affect kidney function, they can adversely affect blood pressure, they probably increase the risk of cardiac events such as heart attacks, they can affect the stomach. And so whereas they're recommended, they are a problem to use. Intra-articular corticosteroids can be a benefit, and I sort of like these in the management of osteoarthritis, in particular of the knee and hip. The risk of those is locally. There is a concern that there may be a slight increase in the rate of damage of osteoarthritis if they're used too frequently. However, used judiciously, probably not. Tramadol again is listed as a treatment option for osteoarthritis. Again, the challenges of using a narcotic type drug in the year 2022 in the United States. Topical capsaicin can be a benefit, although I would submit I don't know how one would put that on the hip. Things that are not recommended: glucosamine and chondroitin sulfate. There's just not been any data really to suggest their benefit, although I have not found any side effects from these in my patient practice. At least if people wanted to use them, I let them. I didn't really stop them. It's their money, but I don't know as it offers any benefit. Another thing that's recommended against currently is intra-articular hyaluronics. These are things, some patients refer these to chicken grease. The early products were made for rooster combs, basically hyaluronic acid. It's injected in the joint, sort of a thick viscous gel. Medicare even covers it for the knee. However, really the data to support its benefit is not good, and so really not favored. And again, opioid narcotics are not recommended. Now, I next want to talk about the therapies that are not favored. The problem with osteoarthritis is we don't have any good treatments, and it's my feeling when there are no good treatments, then everybody has a treatment, and I think that's unfortunately what happens with osteoarthritis. Now I just have this table up for you to sort of glance through while I'm chatting. This is again from the ACR 2019 recommendations with respect to the treatment of osteoarthritis, and it actually is available without membership in the American College of Rheumatology at this web address, the whole paper that I'm referring to actually. So things that are not recommended: number one, glucosamine and conditionally chondroitin. We talked about that. Fish oil and intra-articular hyaluronic acid. Again, I talked about all those things. There's several things that one would consider experimental but are not, and let me just say what I think a true experiment is. And the reason I say that is these are offered to patients as experimental therapy, but they're not really in an experiment. And an experiment that is testing the benefit of a treatment, number one, is blinded. And what I mean by that is you don't know what you're getting. And a better study is even what we call double-blinded, which means both the patient and the treating physician do not know what they are getting. There is a placebo-controlled arm. So there's a chance of either getting the treatment or getting a sugar pill if it's a medication, or if it's a procedure, a sham procedure. So sort of made to look like the procedure or not. It's usually free. The studies where we're truly testing medicines that are going to be presented to the FDA for approval do not cost anything to the patient for the treatment. And that's a hallmark. If they're charging you, you have to ask, is this really experimental? Are they really doing experimental therapy? And there should be a consent that explains all the risk and benefits. So that's what I would consider an experiment in treatment. Now, the types of things that I'm talking about that are offered to patients, I think it charged to the patient, because I don't believe insurance cover these because they're not really shown to be a benefit, are things like prolotherapy. And basically what that is actually needling around a tendon or a joint, injecting something sort of irritating such as concentrated glucose solution. So prolotherapy, platelet-rich plasma, stem cell therapy. These things are offered to patients, but at least right now there's no good data to support them. It would be nice to have good studies to show if they do or indeed not work, but that's not what's being done. They're just being offered to patients as experimental without really being an experimental protocol. Another point I want to make is about testimonial data and anecdotal data. Typically with a lot of these treatments that are not recommended, such as the platelet-rich plasma, the prolotherapy, the stem cell injection, you'll oftentimes find that the people that do these treatments, the therapists, physicians, whatever, that do these treatments, will have web pages full of testimonials, people that stating they did the therapy and how much better they got. One of the problems with any pain management, especially studies with respect to pain management, And in particular with respect to osteoarthritis, that when studies are done, good studies that are placebo controlled, in other words, they're controlling the treatment to a placebo or a sugar pill, one thing they find that there's as much as 50% placebo benefit. And what that means is people that are giving the sugar pill get better too. And so in order to determine if a treatment really works, they're comparing it to that 50% benefit to see if there is benefit in addition to that, if there's more than 50% of the people responding. So if you take an uncontrolled group of patients and give them your treatment, you will always find people that can state, gee, this really worked for me, what we would call a testimonial. And so I wouldn't give that much credit when you see the advertisement stating I did this treatment and look how much better I got. I wouldn't give that much credit at all. And then the other thing that's listed on this list are what are the disease modifying therapies for rheumatoid arthritis. These have not been shown to be of any benefit in the treatment of osteoarthritis. Now, treatments that I think do offer a lot of benefit to patients is surgical replacement of joints. I think the orthopedic surgeons are getting very good with hip and knee replacements, and when patients progress to the point where they need those, I favor it. I'm all for them. I think the big challenge with respect to those therapies is occasionally I have encountered a patient that they're not felt to be a surgical candidate due to either other comorbid diseases or age, in which case, how do you manage those? And unfortunately, those are the patients that we are doing probably too many corticosteroid injections. We are trying the hyaluronic acid injections just to see if we can find something to make them function. The thumb, the first metacarpal phalangeal or the first carpal metacarpal joint can be reconstructed with tendon, and I've found that to be a very good therapy for my patients with hand osteoarthritis. Now, what's the prognosis of this? With respect to the knee, patients with varus deformity will continue to deteriorate. Patients with hip disease over a 10-year time, only about 17% deteriorated. So not everybody inevitably ends up with a joint replacement. With respect to the hands, the prognosis is better. We talked about nodal generalized osteoarthritis usually do very well with their hands. I mean, the hands are funny looking, but they function just fine. The patients that have first carpal metacarpal joint involvement, the prognosis is less clear. So in conclusion, osteoarthritis is a disease with cartilage loss, a lot of times associated with a history of injury or associated with aging. There's very low inflammation associated with it. There's no treatment to reverse it, but there's a lot of things that we do to make people live with it, continue to function with limited pain. I thank you so much for listening to my discussion of osteoarthritis. I hope this was useful and helpful. The next talk will be on fibromyalgia. Goodbye.
So that concludes this talk. I thank you very much, and there'll be further to follow.